So, good day, students. Start our lecture. Our lecture: thermal injuries, thermal gun, cold injury. So, burn or combustion are injuries which arise as a result of local thermal, chemical, electrical, and radiation exposure. Thermal burn primary involve skin as a borderline organ and the mucous membranes of respiratory passages. In time of peace, thermal burn are most common. Burn as a battle trauma may be caused by incendiary mixture, nuclear weapons, heat flashes, which can include burn of skin, and cause damage to visual organs. The most serious injuries result from big disaster caused but inflammable mixture and dust gas mixture, which in days deep burn 77% of the injured people, and burn shock 65%. During air accidents, the injuries with deep burn make up 32%, whereas burn shock is observed in 42% of cases, acute respiratory failure in 29%. In cases in thermal injuries, emergency medical care must include a number of measures, such as rendering first aid as the flashpoint classification and evacuation of the wounded people, as well as a hospital treatment. A four-stage system of care for patients who suffered from a burn has been wounded in our country. One stage, delivery of care at the spot of the accident. Two-stage, general surgical unit. Three-stage, burn unit. Four-stage, burn center. Each evolution stage has to achieve definite goals and provide definite medical service. Total skin service area ranges from 1.5 to 2.5 meter. When the area of burn lesion is assisted, the area of 1.7 meters is regarded as a baseline mean value. Sweat and the glands, and especially hair follicles, determination the potential of skin for regeneration. Skin has three capillary layers: one epidermis, superficial, located in the papillary dermis, two derms, middle layers located at the level of switch glands and hair follicles. 3 hypoderms is located unit the dermis. The cells of the germinated teeth layers obtain nutrient by means of diffusion. The cells of the epithelial lining show relatively small sensitivity to oxygen deficiency and pronounced ability to be accepted and grafted. The numerous skin functions which have not been completely explored yet include thermal control, disintoxication, respiratory 1% of the total gas exchange, enzymatic, immunological function, and that of being a blood depot, up to 1 liter. Thermal burn is an injury of living tissue induced by exposure to thermal agent, which causes protein coagulation, inactivation of cell enzymes, metabolism disordered due to higher temperature. First of all, skin cover is affected, mucous membranes, and delivered tissue and airways are less frequently damaged. The temperature threshold of human tissue vital activity is about 45 degrees. Therefore, the depth of a thermal burn depends on temperature, rate of exposure, physical properties of damaging agent, as well as the thickness of skin or in different parts of the body chronics. The clinical course of local wounds process and the severity of general disturbance in the body are conditioned by the area of damage. A wound process caused by thermal burns in unspecific and shows plasma-dependent general biological patterns dependent on the severity of tissue damage. The initial phase exudation and inflammation infiltration, 7 or 10 days. It is followed by the phase demarcation and rejection of necrotic tissue, 2 or 3 weeks. Then granulation develop 3 or 4 weeks. The regeneration phase complete the evolution of wound which undergoes epithelialization and cicatrization, scarring. Classification and clinical presentation of burn. In our country, info degree classification of the depth of thermal injury was adopted at the 27 All Russia Congress of Surgical in 1930 years. Or 1 degree involved damage to epithelial layers of skin associated with hyperthermia, skin infiltration, and inflammatory exudation. Pain acute in the damaged area, which abated after 1-2 days. Edema and redness disappear after 3 or 4 days. Degree 2 involved dermal damage, which is associated with its determined and formation of blisters filed, which transparent content. Severe pain and burning sensation persist at the site of the burn, and after 2 weeks, and damaged skin areas become completed epithelializing without forming any scars. Degree 3A involved particular skin necrosis. However, deep in line lies of derma and its appendages are preserved. The epidermis gives rise spontaneous restoration of skin color. Degrees B involved complete death of skin and its appendages, frequently hypoderma and affected. Suppurative and demarcation inflammation lasts 2 or 3 weeks, then the wound cleans from necrotic tissue, and by the end of 4 or 5 weeks, granulation suitable for 3 autodermoplastica fill the wound. Degree 4 involved the death of underlying tissues, musculinous, tendinous, bones, and so on. In such areas, deep wounded appear, and they don't tend to the spontaneously health epithelialization of scar. Depending on the ability for spontaneous health, burn are classification into superficials, degrees 1, 2, and 3A, and deep, degrees 3B and 4. Based on the severity of thermal injury involving assessment of the area at the depth of a burn, patients with a burn are divided in 4 groups. Patient with mild burn of the degrees 1 to 3A, which with the area up to 10% of the body surface. Patient with moderate burns of a degree 1 to 3A, with the area from 10% up to 20% of the body surface, plus burn of a degree 3B4, with the area up to 1% of the body surface. Patient with the severity burn of the degree 1 to 3A, which with the area from 20% to 40% of the body surface, plus burn of the degrees 3B 4 with the area from 1 to 10% of the body surface. Always the affected regardless of the severity of skin cover damage. For a patient with extremely severity burns of the degrees 1 to 3A, with the area over 40 of the body surface, plus burns of the degrees 3B4, with the area more than 10% of the body surface. The assessment of the depth of the burn is based on the local clinical things, hyperemia, presence of blisters, and information on shear crust. Typically, the final assessment of the depth of a burns become possible only after is shared in detail after 2 or 3 weeks. Besides burn severity, the assessment of the size of the affected area, total burn area, is a great importance. To determine it, the total area of burn surface is calculated using the rule of nines, Wells rule. According to the rules is nines, the area of covering of a particular body parts is equal to 9% of the body surface, or divisible by 19%, 9%. Head and neck are estimated as 9% of the total body area. Anterior surface at the turn 18%, posterior surface of the trunk 18%, legs 18% each, premunus perineum 1%. In child and body, proportions depend on the age, therefore the modified Lang-Burns chart is used to assess the burn surface area. When estimating the percentage of burn area in patients with the small burns areas and multiple burns located in different body parts, palm rule is used. An adult person's palm is considered to make up 1.0 to 1.2% of the total body surface. Summing up the number of such measurements, and you can obtain the percentage of total burn area. Is specialized hospitals, they use Dolan methods. The methods involved driving human body contours in the patient's medical record. They are divided into segments, each them amount to 1% of the body surface. Depending on the burn localization and depth The involved segments are cross-hunted. The some segments make up the percentage of burn area in relation to the total body surface. Burn shock classification. Burn shock is a general reaction of the body to severe thermal injury associated with the functional and morphological disorder and for of all organs and body systems. Burn shock usually develops when the burn area exceeds 20% or 30% of body surface, or in the case of a deep burn involving 10% of the body surface. Moreover, in a patient with combined thermal and mechanical as well as multi-factor injuries, it can develop when a smaller area is affected. Apart from the general area and this of the following things, and typical of a burn shock. Severe pain, experiment of or retardation topical phase, marked source chill, muscular tremor. Apart from the injury site, skin covering is pale, cold by the feel, has a marble-like shadow, result from peripheral vasoconstriction, acrocyanosis develops. Decreased body temperature, tachycardia, and decreased pulse volume, shortness of breath, diminished diuresis, hypotony, and burn urine with a burn smell are regarded as poor prognosis clinical signs of burn shock. Based on the severity of a clinical manifestation, 3 degrees of shock are recognized: mild, severe, and extremely severe shock. Mild burn shock, degrees 1, occurs when the burn area is up to 20 of a body surface, or for deep burn up to 10%. The shock lasts 24-36 hours. In timely treated, the prognosis is favorable. Severe burn shock, degrees 2, develop when the burn area 21 or 40% for deep burn up to 20%. The shock lasts 48 or 72 hours. In timely and age quality treated, most patients will be resuscitated from severe shock condition. Extremely severe burn shock, degree 3, occurs when the burn area is over 40% of the body surface. For deep burns, no more than 40%. It's associated with the severity functional disturbables of all organs and the body systems. Lately, for the condition of extremely Severe burn shock is about 80%. The rates of the shock in vision is 60 or 72 hours. The final diagnosis of the degree of shock severity requires dynamic observing of patient within 12 or 24 hours. Super strong stimulation of the central nervous system with pain impulses from the burn wound plays a circular role in the burn shock genesis. The physiogenetic reaction, the score of skin damage and underlying tissue are the scientific important too. Burn shock impacts microcirculation and metabolic process, increased capillary permeability, which result in the fact that liquid part of a blood escapes from a vessel into interstitial space. Hemoconcentration arises, concentrated increased to 60 or 70%. Hemoglobin level 2 or 200 g liter. Plasma loss reaches 10 or 30%. The terminal shock severity Frank's index is used. It's calculated by putting together superficial burn area and triplet deep burn area. The modified variant of a Frank's index is injury severity index, DSI, with which gives an idea of a deep burn area. According to this index, 1% of superficial burn makes up 1 unit, and whereas for deep burn, 3 units. In the case of airway burn, 20 units are added to DSI. A mild shock of a degree 1 shock developed when a Frank's index ranges from 30 to 70 units. Severe shock of a degree 2 shock, Frank's index from 70 to 120 units. Extremely severity shock or degree 3 shock, Frank's index over 120 units. In the case of burn of upper respiratory airways, another 20 units are adjusted to Frank's index. Burn disease is a set of functional disturbance of different organs and body systems result from extensive and severe burn. Burn disease severity is conditioned by the area and the depth of tissue damage. 4 periods are recognized in the clinical course of a burn disease. Burn shock, 1 or 3 days. Acute burn, toxemia, 3 or 14 days, septic toxemia from several weeks to several months, recovery period from several months up to 18 months or more. First and pre-medical care involved ending exposure to a thermal agent, ensuring with patency, cooling the burn surface, prevention of a burn wound, contamination from external environment, application of dressing, the simplest anti-shock mixture, introduction of analgesics, satisfying thirst with a salt and alkaline drink, 2 spoonsful of sodium bicarbonate and sodium chloride per 1 liter of water. The distinction of the first medical aid is that infusion therapy is started. Moreover, and any impact on burn wound should be minimized. Adjustment of the either applied dressing, and if they have not been plated, dressing wound with Coletex, Altex F, Altex X bandage. Titanium vaccination of performed. The keystone of anti-shock treatments is infusion therapy. Professional medical aid included the following mixture: medical triage classification and of patient when there is a massive influx, comprehensive anti-shock therapy in burn patient in the burn shock condition, emergency restriction of a patient with airway damage, treatment until recovery. The regimen anti-shock therapy from burn patient included a number of compulsory elements. Introduction of 3 casualties, role of the 3 casualties. Gastritic tube, another into the central veins for infusion therapy, and third one into the urine bandit to monitor how rapid their races. A probe into nasal passages for oxygenation. Novocaine blockade. Vagosympathetic blockade if acute respiratory fail to suspected such and condition, and paranephral blockade, fracture suit blockade. The effective consisted not only the analgesic action, but also in a normalization of capillary permeability. The optimal requisite for effective treatment of thermal injuries is admission to specialized hospital, which is not always possible. Therefore, treatment of burn shock is of top priority, whereas the Subsequent stages of a burn disease are attended to by specialized medical case units. In the case of extensive burn and burn shock, infusion therapy is conducted using the 00 formula. In the first 8 hours after the injury, the felt volume is determined by adding 2 0 to the burn area. For example, is to 20% and 2 liter liquid. There are many regimens for burn shock treatment. Approximate regimen in relation to shock severity present in the shunt. It's also necessary to provide prevention and treatment of respiratory disorders. They included tracheobronchial lavage, inhalation with hemidiaphragm oxygen, introduction of broncholytic agents. There are 2 months direction of intensive cares. Of intensive care of circulatory homeostatic disturbance, which are of significant importance for stabilization of hemodynamics and ensure optimal oxygen transport in the body. The first direction involved the maintenance of effective circulatory blood volume. The second involves nutritive, medicamental, and transfusion correction of amenorrhea, the transfusion of erythrocytates condition, transfusion media, preferable plasma-free media. Acute burn toxemia is the second period of a burn disease. It's manifested by the development of endogenic intoxication syndrome in response to the penetration of incomplete or disturbed metabolism products into blood, degradation of damaged tissue, and hematosis organs. The main tasks of the treatment for the acute burn toxemia are as follows: desintoxication, anemia prevention, hypoxia prevention and correction, local treatment of a burn wound, treatment. Acute burn septic toxemia is a third period of a burn disease associated with a toxic infection pathology manifested as a development of pyogenic and pathoreflective process in a burn wound and responsive vegetative microorganism, their toxins, and products of autolysis of necrotic tissue into the bloodstream. The diagnosis is based of identifying purulent responsive fever, progressive anemia, eosina and lymphopenia, communicated secondary infection, pneumonia, erosive and ulcerative lesions of the gastrointestinal tract, bleeding and septicus in a patient. Treatment. Prevention of infection complication management of anemia and protein deficient operative repair of skin covering integrity. Local treatment of the burn wound can be provided in two ways. Conservative and surgical. There are often combined conservative treatment is the only or and final treatment for superficial lesions of a degree 1 or 3 degrees. It open, bandage free, or closed using a bandage way is used. They start but debridement and burn wound with warm soapy water, detergent or shampoo. Then surgical spherical treatment of the wound with 3% hydrogen peroxide solution is performed. After debriding and drying, the wound is swabbed with a cotton pellet soaked in 5% potassium permanganate or 1% iodinate solution. Dressing and antimicrobial water soluble base on levocin, levomicol, 5% dioxidine ointment are applied on where necrosis ceased, wet or to dry dressing soaked with antiseptic agents on dry site. Protective biological covering, Biacol-1, Algimaf, Opside, Collapson, and so on, are also used for active cleaning of the wound preparation covering Gelicel, Celosorb, Polysorb, and Apleted. The radical pathogenetic methods of deep burn treatment are surgical necrotomy and autodermoplastica. If it is too late to perform an early surgical necrotomy, then 40% salicylate ointment may be helpful. It's applied on a burn crust, then is dry or moderately wet dressing with antiseptic solution is placed for 48 or 72 hours. Chemical necrolysis is performed on an area up to 10% of the body surface. Skin cover or repair is performed with the help of different types of plastic surgery. Severe grafting, free flap plastic with lip thickness skin grafts, pinch, grafting combined all autodermoplastica, flap covered of a wound, and so on. Then problems of thermal injuries is very pressing as they frequently occur during this assessed no for complicated pathogenesis and treatment due to the extensive and deep damage. Delivery of care to burn patient at different stages is based on the above stated principles. The adherence to the principles in the conditions of peacetime disaster is a prerequisite of optimal treatment outcomes. Freezing injuries or limbs. Emergency care and treatment etiology, where the conditions including freezing injuries, condition of thermal protecting of limbs, tire for footwear, local compression, general body disorders, local disturbance. Pathogenesis. The pathogenesis of deep freezing injuries involves a refractory spasm of capillary and small arteries, which causes cold ischemia, show blood flow, and status development. The destabilization developed during the pre-reactive stage, at the reactive stage after rewarring intravascular change aggregator. After the spasm and stase, thrombi begin to form, which the result of necrosis and disturbed arteriovenous circular changes in the tonus of vascular wall permeability due to the impaired tissue nutrition. Signs of thrombi formation appeared on the 3 or 4 days of the reactive stage. When a frozen limb gets warm, the normal limbs of the ledge arteries, first arteries, then veins, restores, which results of an extensive filling of capillary network and congression. Persistence vessel pairs and show blood flow include plasma loss, blood thickness, thickening, and aerocycle segmentation on vessel walls. Frost beaters cause specific cold activation of internal and external mechanism or coagulation. Effect of low temperature. period and degrees of freezing injuries of limb. Period and two periods of freezing injuries are recognized, pre-reactive and reactive. Pre-reactive of hypothermia period, uh, it lasts from severe to 24 hours. During this period, skin is a pale cyanotic, could be the field and low sensitive or intensive. Active period involved warmth of the lymph and blood circulation restoration. The lymph warming, redness, tingling, in hiding pain and edema and observed. Skin cold, redness of a skin color. Classification. Degree 1, response to cold is not intensive. Um, in, inside centrifugal tissue hyperemia, skin pallor is replaced with hyperemia after warming. Sometimes cyanotic or mobile team are observing. When warm touch in the pain severity, pressure, active movements. Degree 2, exposure to cold is not intensive. The diagnosis is apparent when blistered with a light colored content from 2 days. The germinative layer of skin is not damaged. Degree 3, long exposure to cold and degree damage. Early formed blisters as a fillet with bloody content. Degree 4, prolonged exposure to cold, the injury borderline lays at the level of bones and joint. Skin temperature in the reactive period is dramatically low. Freezing injury zones according and argued. First zone, total necrosis, zone of the irreversible degenerative process, zone of reversible degenerative process, for zone of accidents in pathophysiological process. Clinical presentation. Degree 1, pain of different types. Skin is always hyperemetic and warm by the feel equal dilation of both three of the capillary loop. Degree 2, pain is more severe and for prolonged associated with itching, burning sensation, and tissue tension. Edema, epidermal blisters filled with serous fluid. Capillary changed similar and to degree 1. Degree 3 pain is more severe than for degree 2. Necrotics of all skin layers, which may also affect subcutaneous adipose tissue. Blisters are filled with hemorrhagic fluid, demonstrated touch and temperature sensitivity. Capillary tools are diffusely dilated. Degree 4. Hemorrhagic flaccid blisters may quickly form in small amounts. New blisters may form after 1 week. Demarcation occurs by the end of 1 week. Clinical chronic freeze injury. Etiological factor local expansive cold. However, the clinical representation of a chilled blend in similar of freezable of a degree 1. That is actually child blend is a chronic frostable of degree 1. The factors contributing to the development of a child blend are higher immediately at the wind. Chamberlain might occur both at moderate minus temperature and plus temperature from 0 to +5. Child blend develop on the open parts of the face, hands, fingers, and feet. Edema is not present, skin cracks may form. Trench foot. Trench foot is a sold suffering crossable in the trench was described by army doctors. The changed air and in wet footwear. The disease start with granular loss of thermal sensitivity, which occurs in the toe area and then advanced to the sole and the black of the foot. Clinical presentation, skin pallor, foot number of blindness, and edema, blisters, and difficult edema. From the first days, purulent resorptive fever, intoxication. Changes is a homeostatic indication. No changes are registered in the pre-reactive period. In the reactive period, there is increased leukocytose, ASR, leukocyte left shift, hypo and dysproteinemia, anemia, increased blood viscosity, and systems formed elements of blood, hypercoagulation from 2 or 4 days, max by the end of the 1 week. Special methods of investigation: radiography, in a later term, 25 or 30 days. Rheography, increased resistance of higher frequency current and longer time of a quick refill and registered. Afterwards, decreased tone of a large vessel. Show refill time which indicate abrupt narrowing of the total vessel lumen. Radionuclide method of diagnosis of injury depth. Determination of the activity of creatine kinase, tissue-specific enzyme found of the muscles. thermography. Microbiological code of injury. Gram-negative bacteria began to the host. Gram-positive. Gram-positive staphylococcus. Gram-negative blue pus bacillus at Pseudomonas aeruginosa. Three methods of quantifying microbial content: dissection of tissue parts, vapor rinse technique from the disable range. Treatment: first, woman hot drink massage from periphery to the center, bed rest to the elevated position of injured limb, warmly wrapped shared blanket with the Novocaine. Conservative treatment, infusion and transfusion therapy, real polyglycine, glucose, Novocaine, Vita B1, Vita B6, nicotine acid, vitamin C, heparin, tetanic enotoxin, anti-tetanic serum, staphylococcus enotoxin, gamma globulin, anti-staphylococcus globulin, Timoline, Timohe. Surgical treatment: necrotomy from severe days to weeks, necrotomy from 1.5 weeks and later, primary amputation from several days to 2 weeks, amputation, exarticulation, and reamputation after demarcation area is clearly identified, starting from 30 weeks. Tangential necrotomy, osteonecrotomy, starting from 2 weeks and later. Surgical repair of skin covering, starting from 3 weeks. Reconstructive and reparative surgery, a few months after the injury. Complication: early degenerative sepsis, local separation, acute lymphangitis, abscession, and phlegmons, and acute purulent arthritis. A late osteomyelitic and topical trophic ulcers, prison injury consequence, obliterated disease of lower limb vessel, neurosis, and skin disease. Thank you very much of the attention. It's a finish our lecture. Bye. Все, Андрей.